Hello, everyone. Lovely to see you all here again, and welcome to part 2 of our Genomics Health Professionals Education event. Hopefully, quite a few of you joined us when we were here a few weeks ago, but I also know there are some of you who couldn't be with us a few weeks ago who have either watched it on YouTube since or are joining here just for the second part. So a huge welcome to every single one of you. So just to kick us off, I'm going to start by finding out where around the UK, perhaps even the world, people are joining us from. So a little poll is going to pop up on your screen right now. And if you could just get your fingers warmed up by telling us where in the UK you are joining us from, that would be great to get you warmed up, get you working. We've got lots of England, come on, Scotland, Wales, Northern Ireland. Oh, well done, Wales. Nobody in Scotland? No one in Northern Ireland? Okay, that's great. Thank you. And our second question is that we know that quite a few of you might be watching with somebody else. So you're showing up for us as just one person, but there might be more than one of you perhaps gathered round in the office. So our next poll question is how many of you are watching? So if you can just let us know, that'll give us a great idea. Got lots of solo viewers, a couple of pairs, that's good. No threes, no fours? Okay, ones and twos, that's brilliant. Thank you very much. So, as I said before, welcome. I'm Catherine, Director of Services at Bowel Cancer UK, and I'm delighted to be bringing this event to you this afternoon. So a little bit of housekeeping just for us to run through, explaining a little bit about the format of the session and the different tools that you'll need during the session. So first up, important to say, today's session is being sponsored by Merck. So Merck have provided a restricted medical grant to support this virtual event, and they've had absolutely no input into the agenda or the content of this virtual meeting. So moving on, we have a chat box. So at the bottom of your screen, you'll see a toolbar, and one of those will be a speech bubble and it will say chat. And if you click on that, that's where we want you to say hi to each other, introduce yourselves. There are members of the Bowel Cancer UK staff team in there, prompting, answering questions, signposting to support services that we have that can help. So feel free to use the chat at any time. And it's also a really good place for you to tell us what you found helpful or interesting and give us feedback as the session goes on. That would be great. A couple along to the left on my screen, I'm sure it's the same on everybody's, I think, is two speech bubbles labelled Q&A. And that's where we really would like you to post any questions that you have for our speakers during the session. So if you can try really hard to remember not to put your questions in the chat box, because I can't see them if they go in the chat box. If they go in the Q&A box, then I'm able to call them up and ask the speakers them as we go, and then you'll hopefully get an answer to your question. We will do our absolute best to work through everybody's questions. Occasionally, we either get a question that we don't know the answer to and we have to take away and find an answer out to, and we'll follow that up with you afterwards. If we get so many questions, we don't get time to answer them all, then we'll ask our speakers to help answer them afterwards, and we'll send those out when we contact you all after the event. So also just to let you know, we are recording today's session. So we will email you the link to the recording at some point in the next couple of weeks, so you can play it back and revisit the information at your leisure. Nothing you put in the chat box shows in the recording, so feel free to introduce yourselves in that box and that won't be included on the recording. There's also an infographic that features in the presentation today, and that will also be included when we send out information and the link to the recording after the event. So before we start, one more reminder, there is, of course, the evaluation. There's always an evaluation. So we'll be emailing you out a link to a survey after this. We really, really appreciate it if you could just take the time to fill out that evaluation form. Tell us how you found the session, what was useful, what we might do better next time, or any suggestions that you might have for future sessions that we can build, because we really want this program to be driven content wise by what you, the audience, want to see us put on. If you do complete your evaluation survey, you then get your certificate of attendance, which you can then put towards your learning hours. So if you give us an evaluation, we'll give you evidence that you were here. That seems like a really fair deal to me. So I'm now going to move on and introduce you to our speakers for the day. So I'm delighted to welcome back our speakers from last time. We have Dr. Terry Porritt. So Terry was a ward sister at St Mark's Hospital before joining Homerton NHSFT as a CNS in stoma care. She's worked as a nurse consultant and was clinical director of the North East London Bowel Cancer Screening Centre. And she's currently working as a strategic project manager. So hi, Terry. And our second speaker is Vicky. So Vicky Cuthill is lead nurse and manager at the St Mark's Centre for Familial Intestinal Cancer. And she's also a Macmillan Genomics clinical fellow. So welcome to you both. I think I'm handing straight to you, Terry. So without further ado, enough of me and over to the reason everyone turned up today. Over to you.
So realistically, I want to reassure you, I am the very, very brief warm-up act for the main event, Vicky Cuthill. So what I'm going to be doing is really just very quickly talking about why, when we're evolving, developing services, we need to ensure that actually we have up-to-date documentation, job descriptions, etc., to help us develop our services. We're then going to hear from Vicky, who's going to look at applying genomics into your practice and really looking specifically at the Lynch Syndrome patient pathway. Then we're going to have the Q&A session and any summary and next steps. So without further ado, as specialist nurses, we have always had a challenge in demonstrating to people what we do. Often a lot of what we do is unseen. And if it's unseen, people don't value it. So then when we ask for an increase in staffing, if we ask for another team member, that actually it's a real challenge because they don't actually understand what we're doing. And so in the light of the challenges we have, alongside Professor Alison Leary, we developed a standalone website called Apollo, which actually gives you the tools to do this. And most importantly, it tells us that it's okay to be proud about what we do. It's okay to use really positive language. So on Apollo, one of the first things I would ask that if you look at this website is to look at this very short section about phrases to avoid, how we dumb down what we do. So first thing, let's get our language right. Once we've got our language right, let's start talking about the positive standalone nurse-led components to our role. We are not just the handmaiden to the colorectal oncologist and the colorectal surgeon. You have a very, very distinct nurse-led service. Let's make sure we make that clear. Then people say to me, people don't understand what I do, but if I write an annual report, they don't look at it. Okay, there's a very, very simple service summary on 2 pages that highlights the key things that your colorectal cancer nurse-led service delivers. Again, it's a template with examples from practice that you can copy and paste from, so you don't have to reinvent the wheel. But the most important thing is job planning. Do people really know what you do? They might know you're in outpatients, but are you just seeing patients in and giving the notes to the doctor? No, of course you're not. But actually, many people don't know the complexity of what you do in your clinic and clinical settings. So this job planning app, if you haven't already tried it, takes about 15 minutes. It's drop-down menus. You talk about, firstly, where you work, and then what you do in that setting. And once you've completed it for the week, you download it, it comes onto your computer as an unbranded Word document where you can then add any of the extras that you do that aren't covered by the drop-down menu that is on there. And then wrapping all this up is the annual report. which I have to say the first time you do one is a total pain, but with the information we have here and some templates for you to use, I think it's really important, because if we don't tell people about what you do, but also the challenges that you have, you're not going to get the extra resources, the admin or secretarial support, etc., that your service needs. You know, we often make a mistake that thinking that our managers are telepathic, and but actually they don't become managers and get given a crystal ball. It's our responsibility, and it's our way to advocate for patients. So KPIs can be really, really important. And on the Apollo, there is a section about developing KPIs for your role, and Vicky has very helpfully put together this new KPI that about your service with regard to Lynch syndrome, Lynch family work, that you can actually use, and we can help you to make KPIs so you can monitor your service. But bottom line, an up-to-date job description is really important. I bet many of you, since you became in post, your job has changed. You're doing extra things. You might be doing genomic counselling with patients. Is that in your job description? Make sure it's up to date and your manager signs this off. Not least because if it's not in your job description and there were to be an issue, you don't have vicarious, you have liability. Your trust does not, because they will say, we didn't know she was doing this, we didn't ask them to do this. So an up-to-date job description, really important. And actually this is advocating for you, and it's advocating for your patients. If you don't shout about what your service needs, you're not advocating for patients. And actually, you know, I think Charles Darwin was right. We don't have to be the strongest, we don't have to be the cleverest, but actually we have to be the most responsive to change, and we owe that to our patients. So the infographic that you have will take you to all the helpful tools on this standalone website, hugely developed, and the resources from Professor Alison Leary. So genomics is not going to go away. It's really, really important. It's an integral part of your role, and as you develop your service now. So the tools on Apollo can help you demonstrate that. But let's hand over straight away to Vicky and talk about the future-proofing your practice in genomics in cancer care.
Thanks, Terry. Right.
Yeah, just your warm-up act, Vicky. So over to you now.
So the sorts of things that I want to talk to you about this afternoon is a little bit, just a couple of minutes about the bigger picture in terms of where genomics fits in healthcare policy, and getting us all as nurse specialists to think a little bit more about the big picture in all sorts of aspects of our role, and then how we can get access to the advice and support that we need from services that are already out there, ready and willing to help us. So obviously in this situation, the Genomics Medicine Service, I'll tell you a little bit more about that. A little bit of recapping about those pathways to bowel cancer. In the previous talk that we gave a few weeks ago, people wanted some more information about KRAS, BRAF and MSI status. I'm going to talk about that, and then I'm going to take out the MSI high status in the context of the Lynch syndrome pathway. So we're going to talk about all of that over the next sort of 25 minutes. So it goes without saying that in everything really, but especially in cancer, that early diagnosis and prevention is obviously key. And following on from the Chief Medical Officer's Generation Genome paper in 2016, in September 2020, we had this white paper, Genome UK, the Future of Healthcare. And it had within it 24 commitments across these 3 pillars that I've put here. But you can see that all of these have a huge part to play in cancer. We want to diagnose people early. We want to treat people with the right medications. We want to prevent cancer altogether. And of course, everything we do is bound by research. So actually, thinking about how all of this fits into the healthcare policy at the moment is really really important. There is a huge, significant drive for this because it benefits patients and people living with cancer. And so we need to get on board. And there's also really great opportunities for us, and I'll talk about that as well. So in January 2021, the National Genomic Medicine Service was established. And you can see here the map of the regions in England, and I've also placed there where the genetic services are available in Scotland, Wales and Northern Ireland. And if you're not sure which service you might belong to or who your local contacts are, then you can email england.genomics@nhs.net. And I'll also be letting you know about my colleague, Laura, who is the National Lead Syndrome Nurse as well. And you can contact her if you need further advice about who to contact and educational resources. So it's a really good idea to get in touch with your local GMSA. They've got huge amounts of resource. They're ready and willing to help you. And I think that actually, you know, one of the jobs that they're doing at the moment is kind of mapping all the kinds of cancer nurses across the country at the moment, and trying to create a network so that we can drive some of this work forward. And what's really interesting is that there are currently kind of 7 national transformation projects, and each area is doing some other sort of smaller projects as well, but 4 of those actually have cancer, that are involved with cancer. So when we think about pathology, which is one of them, that's vitally important when we're thinking about cancer. Lynch syndrome, of course, I'm going to talk about that. DPYD testing and nursing and midwifery itself is a transformation project. There are huge amounts of resources going in to help us learn about this topic and improve care for our patients. So we just need to tap into that. So I showed this slide at my last presentation. So hopefully you'll remember that it isn't to bamboozle you or to worry you. It is to simply illustrate that there are different pathways to cancer. And this is why one size does not fit all when it comes to treatments. And if you remember nothing from what I say today, this is probably the most important thing that you can take away. And that is why we are finding, especially in terms of bowel cancer, that there are different treatments that work for some and not for others. And teasing this information out and finding out which pathways our patients belong to is really, really important. And of course, like I said in the last presentation, cancer is a disease of the genome. It is caused by genetic change. So to say that we don't need to know about this really doesn't make sense. We have to know about this if we're going to understand what's happening in this field, and if we're going to be able to explain it to our patients as well, which is the most vital aspect. So there are lots of known knowns, if you like, in this field, and some of these are now being turned on their head. So we've always said, and it seems very obvious, that surviving bowel cancer depends on how early or how late that cancer is diagnosed. But now, more than ever, we are finding out that certain cancers may respond better or worse to treatment. So in the future, it might be that people who have previously been diagnosed with terminal cancer may well survive. And I'm thinking of those MMR deficient tumours and Lynch syndrome patients that are responding so well to immunotherapy, for example. So we know that, and as I've talked on my last slide, DNA changes contribute to cancer. So these offer potential targets for treatment. And we know that there are certain genetic changes within a cancer that can give us information about targeting treatment. So KRAS, BRAF, and whether a cancer is microsatellite unstable are the 3 really important things that we need to know about in bowel cancer that we can target treatments to at the moment. Now, there's only 3 at the moment, not too difficult. There will be many more, but it's always important to focus on the simplest information. We are not oncologists. We do not need to get bogged down necessarily by which medications where. What's really important, I think, in this field is making sure that the patient's tumours are being sequenced appropriately to ensure that the right treatment is being given. And we can do that in terms of some of this pathway work. Okay, so really important to identify certain patients so that we can get the right therapeutic strategies to them. really, really vital. Now, this is not a slide to stress you out at all. It's just a slide to indicate that there are lots and lots of huge amounts of different genetic alterations when we look at cancers. But certainly in those three different actionable mutations that I mentioned, they play an even greater significance. So when we're talking about things like the RAS genes, of which KRAS is one, and also BRAF, they have really important roles, if you like, in helping cells to grow and multiply. So you can imagine that if there are mutations there, maybe that growth and that multiplication can go out of control. And historically, finding a KRAS mutation means that potentially certain treatments may not be as effective. But as I said, the tide is changing on this as we're finding better therapies for this patient. But as per current NICE guidance, if you have a patient that is eligible for systemic therapy, then you should know the KRAS status of your patient, the BRAF status of your patient, and whether they have an MSI high or not, or low, or you may also hear it heard as mismatch repair, or MMR proficient or deficient. And I'll obviously take that section and talk about Lynch syndrome in just a moment. So KRAS status, really important because we can give targeted treatment, and then also BRAF as well. Now, again, around 10% of patients have this BRAF mutation, and actually it's very uncommon in Lynch syndrome, so it's often used as a surrogate marker. You may hear these genetic changes also referred to as biomarkers as well, and that's all this means, is that there are markers in the blood that indicate that we can give certain treatments. So again, it's known as a poor prognostic marker, but actually now with things like triple therapy, there is hope being offered for these patients, and I think this is the area that is going to change tremendously in times to come. But certainly, if you do find a patient with a BRAF mutation, for example, then and they're not going to respond to standard therapy, then that's really important to know as well. So BRAF, KRAS status, MSI status, really, really important, and should be happening currently in the the histopathology of your patient's tumours. So at the weekend, the American Society for Clinical Oncology met, and it was, I didn't go, obviously, but I was listening, and there was quite a lot of really fascinating papers that came out, and I'm going to talk about the second paper mentioned on this slide in just a moment. But we know from 2020 that immunotherapy was eligible for patients with metastatic bowel cancer, and it has made a huge difference to patients with mismatch repair deficient, and of that cohort there are obviously some patients with Lynch syndrome, and it's turned many patients from being metastatic disease, terminal, to turning them around to having complete response to treatment. It's really, really exciting. Now, 10 to 15% of bowel cancers are mismatch repair deficient. So that's 10 to 15% of metastatic cancers where we can make a real difference, and it can literally be the difference between life or death. So it's actually really, really vital that we have this information. And then at the weekend, I've just made some notes so I don't get any of it wrong. There was a really, really exciting study, and it only showcased 12 patients, but I think that this really is the future. So a study in America looked at 12 patients where with, as you can see, mismatch repair deficient, locally advanced rectal cancer, and they gave them an immunotherapy medication, and if I can say it right, called dostarlimab, every 3 weeks for 6 months. And they had, as I said, 12 patients with stage 2 and 3 rectal cancer, and the patients had between 6 and 25 months of follow-up. And what is really, really exciting about this is that they have so far seen a 100% response rate. So none of these patients have had surgery or chemoradiotherapy. They have so far had no recurrence or progression and no adverse events at grade 3 or higher. So is the future of some types of bowel cancer a future where maybe we can give medication rather than the usual curative surgery? So really exciting, and it's free for a short period only from the New England Journal of Medicine. I really advise you to download that, because it really is such exciting stuff, and I think really illustrates why we need this baseline information when patients are diagnosed with bowel cancer. And just to show you this wonderful picture here, you can see there the 2 patients with the really obvious cancers showing complete progression. So I mean, sorry, complete regression. So it's just, for me, this is really exciting stuff. So hopefully I've passed on that excitement. So just moving on, a reminder of when we might be worried that somebody might have an inherited bowel cancer. So members of the family or the individual sitting in front of you who's under 50, somebody who's been diagnosed with more than one primary cancer, if you have several close relatives in the family diagnosed with a bowel or associated cancer, and obviously if you have multiple bowel polyps as well, that may indicate a polyposis syndrome as well. So we talked about this before. We want to prevent cancer earlier, or diagnose it earlier. We want to tailor treatment. We want to deal with a family. Family is really important when we're talking about inherited disease. And of course, there's surveillance programs that we can place people on that are really important. And I have to thank my colleague Laura, who is the national Lynch syndrome nurse who works with me. I said to her, give me some slides that are slightly different from last one, but I just want to hammer some topics home. And of course, with Lynch syndrome, when we're talking about Lynch syndrome, there are 4 main gene alterations that can cause Lynch syndrome, and it predisposes, main concerns being colorectal and endometrial cancer. There are other less frequent cancers, and it depends on the genetic alteration as to your different risks of different cancers at different ages, male and female. You don't need to worry about that. There are useful tools that you can use, and you can look into this, but it's just really important to know these patients are at very high risk, and that's why we want to identify them, and we want to identify family members as well. So again, just a reminder of the fact that it's inherited in a dominant fashion. So we have 2 copies of each gene, one inherited from mum, one inherited from dad. So if we have Lynch syndrome, we have 1 affected copy. So we have a 50-50 chance of passing on the good copy or the bad copy. And if we pass on the bad copy, obviously our children will then have Lynch syndrome. And another important thing to mention is that there are different percentage risks of getting cancer. So it is possible to go through your whole life and not have cancer. It's not 100% what we call penetrant, but you are at very high risk, and that's the important part. And I think, I've put this slide up because this is Mohak, who's a very well-known speaker now in terms of his experiences of being diagnosed with early onset bowel cancer secondary to Lynch syndrome. And if you haven't yet read the Never Too Young report, please do. It is difficult, but an important read. And he is a prime example of somebody that was given a terminal diagnosis and went on to survive with immunotherapy treatment. So, why are we here? We are here for our patients and for those living with cancer. And that is why, the Lynch transformation program has to be a success. And this is just to showcase in another way the importance of thinking about the benefits of a genomics pathway when we're talking about cancer, because it makes a difference to the treatments that we offer. It might be that we don't have to have surgery at all in the future for bowel cancer in certain patients, and of course we're identifying family as well. So we've really got to think more along these lines. And there are so many opportunities for us. I've mentioned the patients, they're always at the heart of everything we do, of course, but these are opportunities for us as well to develop new skills, to be Lynch champions, to connect, work outside our trust, get secondments, all the work that Terry was describing, making sure that our work is valued. This is a real opportunity for us as well as the patient, and that's really, really important. And you can see Laura's details there if you need to get in touch, if you're not sure who your local contacts are. So we know that, and this is again just a reminder slide in terms of how we can manage cancer risk, and people were asking me about aspirin before, and I just wanted to put this link up for the nice decision aid for patients, which I think is really, really good, and you can direct patients to that if they're not sure about whether they can take aspirin or not. So when we see kind of diagrams like this, I remember when I was first faced with this and was first learning about Lynch syndrome a few years ago, I just felt kind of stressed and thought, my God, I'm never going to understand this. But you really mustn't worry, and you must break things down in your mind. And there are two arms of the pathway at the moment, because it depends on what area you work in as to what the initial tumour tests will be. So for example, at St Mark's, where I work, we do the specialist staining, which is mismatch repair immunohistochemistry on our bowel cancers. But other centres, because it's on the test directory, will do the MSI testing, and that will be sent to the genomic laboratory hub. So it just depends on your area as to which testing is done. So we do an initial test, and if you have loss of MSH2 or MSH6 or PMS2 alone, then the patient can go on and be offered germline genetic testing. But if you have loss of MLH1 or MLH1 and PMS2, they sit quite close together, and that's why you will sometimes get lost together. When I say loss, you will often hear it as MMR deficiency. Or MMR deficient, then you will do a second test to find out whether there is MLH1 promoter hypermethylation. Now, that's a very long word, which is simply something that happens biologically in sporadic cancers. So if hypermethylation is present, Lynch syndrome is very unlikely. Okay, if this is absent, and we also use, as I said before, BRAF as a surrogate marker there. If there's a BRAF mutation, then it's very unlikely to be Lynch as well. So if that is absent, then the patient can be offered germline testing. Now, you can make this as complicated or as simple as you like. If you go onto YouTube and type in promoter hypermethylation, it could take you a day before you understand all the biological processes behind it. But sometimes you just need to understand that, you know, if there's a potential for an MLH1 genetic alteration, you have two tests, and then you can go on to offer the patient germline testing. So I could go into this in much more detail if I had time, but you know, there are lots of courses and lots of teaching available for us to be able to tell you more. And you'll find in the information that's been sent out to you, guidance that has been developed by Laura, my colleague. She is absolutely amazing in the work that she's done for the London region. And now there are Lynch syndrome posts popping up all over the country to support you in your work. So there is standard operating procedures. We've got templates so that you can refer directly to clinical genetics. If you're working in an MDT and you know all this is happening already, fantastic. But maybe you're just doing the first step where you're getting the initial testing done to find out whether the patient is eligible. But there is a potential then to offer the genetic testing yourself, which we call mainstreaming for you as colorectal cancer nurses. And you know, if you're interested, it's a great thing to do, mostly because patients can wait months to access clinical genetics, and if you can offer that genetic test to patients, then it's going to cut down huge amounts of waiting time. There's an audit tool that you can follow if you want to find out a bit more and do an audit in your MDT with support, obviously from your medical colleagues, to find out what's happening. Because really, if you're not sure what's happening in your area, what you need to do is find out, are the tests being performed? If not, why not? And how can they happen so it gets done automatically and results can get fed back to the MDT. And I think we did an audit back in 2019. And for example, what we found out was that the immunohistochemistry testing was being done and it was being reported back, great. But then there were gaps whereby the promoter hypermethylation studies weren't being sent off automatically, and also and then patients weren't being offered genetic testing. And so we refined the pathways, spoke to pathology. You know, a lot of this is team working, speaking to different people, and you're not expected to do this on your own. You know, this is part of a wider MDT effort, but remembering that, of course, being diagnosed with Lynch is one thing, but actually to access a lot of these things that I've been talking about, especially in terms of immunotherapy, all you actually need to know is whether that cancer is MMR proficient or deficient. If it's MMR deficient and you have an advanced cancer, then you're eligible for this treatment. So it's really important, if you do nothing else, that you do that first stage and you find out that those 3 statuses, you know, if your patient is going on to have systemic therapy, you know, it's absolutely vital. If you are interested in then carrying on, you've got the fact that this patient is at risk of Lynch syndrome and you really want to go on and do the genetic testing yourself, then there is training that's out there that you can do. And it really is as simple as the slide that Laura has given me here. You know, you can take a family history and draw a family tree. You can offer the patient testing, and of course, it can be successful. You diagnose Lynch, it can be unsuccessful. We don't get a diagnosis of Lynch, or of course, we may get a variant that we don't really understand what that means at the moment, because we don't have, you know, we're not advanced enough in our knowledge. And then we can get consent for the patient and get the patient sent off, get the sample, sent off and to get tested. And there is a, I can't go into it all, but there's a lovely pathway. And of course, if you do get a Lynch syndrome diagnosis, then at this point you can refer the patient to a local clinical genetics department to ensure that the cascade testing is performed on the family. And this is just an example of the training opportunities that are there, that your local service can take you through and can organise with you. And some of that also includes workshops and one-to-ones, so that it can help with your confidence, because I think that's really important as well. If you've never done this sort of thing before, there's a lot of confidence building, I think, that's needed as well, so that you're confident in your role. And again, just some links, and you'll be getting all of these to the training as well. So I think just to finish up, it's really important that, you know, it's not all on us. You know, I would never say, you know, if we nurses don't do our jobs properly, this won't happen for patients. This is a big, wide MDT project in order to get more patients diagnosed. But I really, really believe that we have a pivotal role here in ensuring that patients follow the correct pathways, the right testing is done on these cancers, the right patients are referred for genetic testing. And I think that if you're interested, then it is really important that we start to offer genetic testing locally to reduce these wait times. It's not work that's a bonus. It's a core part, as hopefully I've explained to you, of the diagnostic pathway. It's used to inform oncological and surgical decision making. And who knows, if we get the right patient to the right medication, the future may be where surgery is not even indicated. And that's, you know, my favorite word, completely game changing. So we need to embed this as core activity, and that's back to Terry's work. You know, I keep hearing on Twitter and things at the moment, you know, CNS jobs being advertised at band 5. What is that about? No clinical nurse specialist who's embedded in role should be anything less than a band 7. And I really think that we can use things like this to ensure that our roles are respected and better understood. And we need appropriate support, obviously, to be able to do this as well. So I've often shown this slide. You know, we are working at an advanced level of practice that is often not recognised, which is why the work that Terry introduced at the beginning is so important, to be proud about what we do, to shout out about what we do, but most of all, to record what we do as well, and to make sure those job descriptions are up to date. My final point is that I'm currently doing a cancer genomics nursing survey. Some of you may have already filled this in, and if you have, thank you. We've had about 180 to 200 responses now, and I would like to close the survey in the next week, if possible. So if you're on the call today and you have literally a spare 10 minutes maximum, it's really important. There's lots of education being developed, but it needs to be guided by you as nurses, and quite often I don't think that's happening, and that's why I'm so it's so important that we find out your views about what you need to know as well. So my take-home messages: always look at the bigger picture. because this will always be influencing change at your working level. So how, how is what you're doing as a CNS, for example, implemented, and how is it affected by what current government policy is doing? Please link up with your local Genomic Medicine Service Alliance and get access to the resources that are on offer. The Lynch Syndrome pathway is just one example of advanced level nursing practice. We work at that level all the time. Use it to highlight what we do, and it's core activity as well. As I said, it's used to inform oncological and surgical decision making. So thanks for listening. I really hope you found that helpful. I'm sorry it's a whistle-stop tour, but of course, if there's any further information, then I'm sure that we can provide it after the session. So thanks for listening.
No, thank you, Vicky, and thanks to Terry. Seems like a long time ago. We've crammed a lot in since we heard from Terry at the top of the hour, but yes, a huge amount of stuff there for people to sort of churn through and process through. But we do have a couple of questions. I'm hoping that a few more will come through because I think people are probably digesting what you've said. But we'll kick off with this one, which is, I'm really interested in cancer genomics, but I'm really busy and it's difficult for me to get study leave. How do I convince my manager that this is important? So I'm guessing this is going to go back to what you were saying at the start, Terry. So I don't know if you want to start with this.
Yeah, I mean, we're all busy. But actually, the importance, the risk of you not being educated or confident to be able to offer this service to your patient is huge to the organization. If you're not facilitating the MDT, documenting, ensuring patients have the blood test, the result is understood, the referral is made. If there's a missed referral on somebody that could have been treated and and potentially not required chemo radiotherapy, as Vicky was talking, and that comes to light and you didn't do that, the trust didn't do that, it's a massive risk for them. So I would always say, how I would position this if I was you was, look, I know this is time out of work, I know it needs cover, but let me talk you through the risk if I'm not on top of this. This is absolutely imperative for patients and for this organization. So if you talk in the terms of risk, that makes people go, we can't not do this. So I would always identify the risk of the missed opportunity to screen somebody, to treat them, the risk of a missed opportunity of actually somebody having their disease, despite as Vicky said, a terminal diagnosis, actually responding to treatment in the new study she was saying. Yes, so that's what I would do. And if you need any help composing an email, I'm quite good at those. So my email address, I can put in the chat. If you wanted to send what you're planning to say and I could help you in any way with the wording, I'd really happily do that. And I'm going to put my email address now in the chat.
Wow, don't get offers like that every day, do you?
It's what we're here for.
Absolutely. Brilliant. Okay, so we've got another question now, which is a huge thanks to both of you. I'm really excited to hear this update. This person says, my role is heavily focused on referral and diagnosis, and I work really closely with primary care in promoting earlier referral and diagnosis, particularly in the under 50 age group. How can we best support and influence, and I think influence might be the key word here, how can we best support and influence gatekeeping healthcare professionals to assess family history?
Oh yeah, that's a tough question actually. I mean, there is lots of through my work with with Macmillan, for example, there is huge amounts of work going on in primary care at the moment. So these transformation projects cover all sorts of areas. So for example, there is a GP lead on these transformation projects. So the work is filtering through, and I guess it's just shouting about what we do in the best possible way, also feeding back. And I don't think we do this enough. If we get a great referral or we get a referral where we think we should have had that referral sooner, we're all busy, but are we feeding back and all of us learning from things. I'll give you an example that we've started doing recently. Obviously, I run a service where we have patients who have got inherited conditions and they're on surveillance programs. So, and sadly, we do get diagnoses of cancer on surveillance. So we now discuss every cancer to make sure that there is no area that we could have done something better, referred someone sooner, and also to say, for example, we know there's backlogs at the moment in endoscopy, so we can say to executive level, right, because of this backlog, this cancer has occurred. And I think, you know, feedback, working with our primary care colleagues, there is a lot going on in primary care at the moment, just to reassure, and lots of great work going on actually. So I think it will filter through. And like anything, this Lynch transformation project's only been going, you know, for the past year. Things take time. I have seen the most exciting changes in the last year. So, you know, we've got a way to go, but it's exciting time. So change is coming and is happening now.
That's really interesting, Vicky, to hear you say that. So that piece of work in primary care, exactly along those lines, you know, how you influence the gatekeeping health professionals at the point of diagnosis or before, you know, point of diagnosis is critical for us, and it's something that is a priority for us at Bowel Cancer UK in the coming months. So we've got some education work happening that we'll be rolling out in primary care, and so I think it would be great to sort of pick your brains on that, because the answer to that question actually is a fundamental part, isn't it, of how you get them to.
And the other thing I was going to say actually, Catherine, is also the work about, you know, that Bowel Cancer UK does so brilliantly about promoting the symptoms of bowel cancer to patients. Obviously, the amazing work that's been done at the moment by Deborah, you know, Bowel Babe, in terms of raising awareness, because actually we as people also should be knowing our own bodies, recognizing symptoms, and then the difficulty is obviously being a strong enough advocate for yourself to say to the GP, do you know what, I'm actually really worried and I actually think that I need a referral, and not feeling that you can't say that and that you can have those conversations. So it's a two-pronged attack, isn't it? It's getting healthcare professionals to refer at the appropriate time with the appropriate symptoms, etc., and people will always fall outside that, but also the work about raising awareness as well, that is so important.
Yes, definitely keeps us busy and keeps us up at night sometimes, I have to say. So we've got another question now. So this is a question from Philippe, who says, what would you say is a reasonable time to wait for a full genomic profile from a histopathology sample?
Oh, well, that's a really difficult, do you know what, that's a really difficult question, only because I know it's so different in so many different areas as well. So I guess it could take, you know, a few days to a couple of weeks. Do you know what I mean? It depends on the area. Reasonable is the shortest time possible, obviously, because you're going to be acting on these results. So they really shouldn't be taking too long at all. And when we first did our audit in 2019, what I should have said was actually one of the issues was the time that things were taking. So actually doing things like an audit, finding out how much time things are taking, and then working on reducing that time scale is probably part of the pathway. But I'm very conscious that things are quite different in different areas of the country. And if you're doing it, in some ways that's great, do you know what I mean? And then these timings can be refined as the pathway is refined and improvements are made. But obviously the quickest time possible is the best, because you're making treatment decisions based on that.
That's great. Okay, thank you. And another question, how do I find out about my regional genetics service and start to make links with them?
So so as I said, there's these 7 regional genomic medicine service alliances, and each alliance will have a number of regional genetics services. So to be honest, the quickest way is to identify which is your particular service alliance, or obviously if you're in Wales, there's the All Wales Genomic Medicine Service, in Scotland, Northern Ireland, and just Google them, and they've all got web pages and they've all got links with information, and and that is probably the best way. And in your hospital, and also if you just Google regional genetic services, each hospital is connected with a certain regional genetic service. So again, you can get whole, and normally, but again, I'm conscious of the differences across the country. Normally, each regional genetic service will have a specialist cancer geneticist and a specialist cancer genetic counsellor, and making those links is really important. And get in touch with Laura as well, because she's kind of building up a network. So for example, if you're a Lynch champion, for example, or you're interested in that sort of work, we can build up that network as well.
Great, that's really, really interesting. Thank you. Terry, anything from you to add on any of those?
Well, I just think that things are moving so quickly. It's a year, as Vicky was saying, and things have changed so much that, of course, as specialist nurses, we need our evidence, our theory underpinning our practice. So we do need time for events like this one, listening to Vicky. But also we need to start from the beginning, and some simple questions, as in the resource that Vicky's provided, about this baseline audit. Where are you all? I think, you know, there's a lot. I have had some conversations with people who are really panicky about maybe what's not isn't happening, and they're really worried, so they're avoiding the whole thing. I don't want to get involved with this, then it won't be my fault. And actually, when they've done the baseline audit, actually A, B, C and D are already being done. They're just not in the communication chain, and so they just get themselves communicating with their MDT, finding out when blood tests have been done, when the results are back, when what the patient's been notified, who's going to do that, what's the MDT discussion. And she was like, okay, this is going to be great. So actually, it's start that baseline audit, as Vicky, and sorry, I've forgotten the name of your fantastic colleague who shared
Laura.
Laura, yeah. And really that will give you the platform with which to then be able to say, okay, I need A, B, and C educational support. I need A, B, admin support. We're not doing this. This is a risk for the trust. Who's going to do this within the MDT? So it really gives you your platform to support yourself, but also your service, and advocate for patients.
And that goes
so
back,
it's absolutely key. Yeah,
that it goes back, doesn't it, to what you talked about in the first session, that thing about sort of becoming the champion for this in your trust, in your hospital, and making it your business. And once you start asking those questions and piecing the bits of the jigsaw together, then you may well find the picture is not as bad as you think, and you are the person to drive the change.
Exactly.
Yeah. And I would also say that, completely agree. Often things are being done that we don't realize it. And that's why I was talking about an opportunity here, because it isn't uncommon for nurses to be left out of the loop, but to be expected to do a lot of the work. This is an opportunity for us to have that seat at the table and to be in a position where we have a say, and can influence that patient pathway. And I just want to say thanks to Deborah from the Northwest GMSA as well, who's kindly put how long it takes for tests in her area, 14 to 21 days. So I didn't want to upset. Our lab is approximately the same, but I do know the situation is different in different areas, and don't want people to go away and go, oh my God, in our area it's such and such, because if it's being done at all, fantastic, and we can work on that. And she's also put the genomic laboratory hubs in the chat as well, so that is really helpful. Thank you.
Brilliant. Well, we have reached the end of the time. I'm afraid we could sit here for hours, but thank you both so much for the last two sessions. Really, really interesting stuff, and I'm sure that there will be lots of questions come out of when the audience have time to go away and perhaps look at the materials, and we may well invite you back. There may well be a part 3, who knows. But huge thank you to you both from everyone at Bowel Cancer UK, and I'm sure watching. So just a little reminder that we've got a number of upcoming virtual events. Some are for patients. So the first one is no, they're not for patients, apologies, this is health professionals. So upcoming educational events for you. First up, we have Evolution of Pelvic Exenteration Surgery on Wednesday, the 13th of July. We've then got the annual NCCNN Study Day and Gary Logue Awards coming in September. And then there'll be a session on the management of anemia before colorectal cancer treatment in October. So that QR code will take you straight through to the information on our website about those events. It'd be lovely to see you there. And if you've got any suggestions for other topics that you think you'd like to see us cover, then don't hesitate to reach out and give us that information as well. Huge thank you once again to our speakers, Terry and Vicky. Also a thank you to the Bowel Cancer UK crew behind the scenes, making all the technology work seamlessly, and slides, and for all the work that goes into putting on an event like this. Thank you once again to Merck for their funding to enable us to bring this to you free of charge. And thank you to all of you, very busy health professionals, for carving out an hour of your time to join us for this chat. So hopefully see you at the next one. And until then, take care, everyone.